How are you doing, Dr. Lobato?
I don't know if she has her audio on. Do, can you hear us? Oh,
I
or
do
maybe.
not. Yes, I do not because I had just walked away. And I'm coming. Uh, yes, I do, and I hear you fine. You guys hear me?
Yep, perfect.
All right.
My pup wants to be in the photo. She's
Uh,
crawling all over me. She can't stand being away from the limelight.
I understand. So does my dog.
We'll
She
do a
spent.
couple. Go ahead.
I was gonna say mine spent all day. I came in for a few hours yesterday and ended up being more like 6. And she was bored by the end.
This is a kind of an interesting case based on the deposits and so it'll be an interesting discussion.
I have a few slides leading up to it if you
Yep.
want, or
Yeah, we'll start
okay.
with some basic housekeeping stuff. I'll just remind people about rounds and stuff like that. I should probably look. This is November, right? So I'm assuming December would still be. Oh wow, I can't believe we're already into the third week of November. Okay, and then December, it'll be on the 16th, I think. Okay, so we'll still be not impacted by holiday stuff. So
Hey Rachel, that Wilms tumor one on that tumor
Mhm.
is positive.
Yay, we did it! Good job on us.
Nice. Good for us.
I was looking at it because I didn't see the age of it, of the animal yet. And so I was just like, gosh, this doesn't look like a straight, like there's areas it looks like it's a carcinoma, but it doesn't look straightforward, especially like some areas a
Right?
little more. And I couldn't f find any like primitive glomeruloid stuff that I was sure of. I mean, I only kind of looked at it briefly and then I was like, oh, it's young.
Um, there's like one little part. I'll take some pictures and stuff,
Okay.
of course, but there's one little part where they almost look like they're trying. Little
Yeah,
little
I think
glomeruloid
that the
feed.
criteria that used to be used were before we actually had the stain
Yeah.
to look at it. So that'll be helpful for them. Whenever you get just send me a text and I'll get it sent out to the clinician.
Cool.
Okay, as we're starting, it looks like we already are recording. And I just want to do a couple housekeeping things as people continue to join. Hi, Dr. Herman. Um, so this is our November session, and Tufts University, their clinicians have had an interesting biopsy in October that they reached out about presenting. And so it does save me one major step if people step up and say, hey, I'm interested in presenting a certain case. We might have a volunteer, Dr. Herman, for December. Do you think you would be able to present in December? I think it's going to be December 16th.
Yeah, I'd love to.
Okay. So we might have December covered, but anytime you have an interesting case and you flag it, then I'll track you down later, and we can make sure that it gets listed for discussion. And we always have kind of just really easy, fast things. If you think your case might not be like take the entire hour, we always can look at a few tumors or something together as well. Speaking of tumors, the kidney pathology service does evaluate renal tumors these days. So some patients or some hospitals have been sending us their kidney masses and their urinary bladder masses as well. I don't want to overwhelm our service, but we're doing a pretty good job of it, and we've got some pretty good IHC working. And so, if you're interested in sending us a certain biopsy from a nephrectomy sample or even a punch biopsy or something like that, please let us know that we can evaluate masses in addition to medical renal disease. Um, So there is that option. Also, as I say every month, we record these. These are stored through the ACVNU database for so that you can watch these later, especially for people who are not in our same time zone, because we do have a few international viewers as well. Um, Summer takes care of putting all that material together for us. So these are recorded, and if you realize you have not been invited recently, you that the invitation hasn't come to you, just reach out to me. Every so often, people get kicked off the list. We just had Shannon McLeland, who is one of our pathologists that reads for us, realize she hadn't gotten an invitation for, I think, September or October. So just don't feel bad about sending me an email to say, hey, I haven't received an invite, because I do at least send out some kind of notification every month. And so if you haven't received something in a month, then it's just Outlook being Outlook. And we all know the funny memes about how Outlook just decides not to do certain things. I want to ask maybe Mary Nabity just to make sure there wasn't an accidental Teams link on the invite, correct? I think I was
Mm,
good at cutting that off.
no, I don't. No,
I
I
was
don't think
pretty
there
sure I
was.
cut it off. I think there's sometimes where I cut it off, and then if I send a revision, it adds it back in. But just making sure that there's nobody on Teams waiting for us.
Yeah, I don't think so.
Okay. Do you guys have any questions? Do you guys have any comments or suggestions for how these rounds proceed? I will say I called into Tufts liver rounds last week on Thursday, and it was very interactive, and it made me kind of sad that ours isn't as interactive. I will say it was very interactive from the clinician standpoint. I'm not sure how much the trainees, other than the one trainee that was presenting the case, but it was a liver disease that had a kidney impact. And so we had evaluated the kidney biopsy. So I called in to present the kidney findings. So I do very much enjoy enjoy the comments that get put into the chat or raising a hand to ask a question. I did not make quiz questions for today, but if I ask a question, it really helps me out if you answer. So let's all be a team about this, because in general, it doesn't need to be just Dr. Lobato and I lecturing towards you. I'd really like to make it more interactive. If you can't see the lesion I'm pointing out to, then um, uh, please interrupt so that it is a learning experience for everybody. It also helps me realize what I might be speaking too fast about, because you guys know I have the ability to speak very quickly. So if you need me to slow down, it does help me work on my speaking skills as well. Okay, so please send any suggestions or comments. I think with that, Dr. Lobato, do you want to start describing the clinical aspects of this case?
Sure. Make sure I can call it up.
It is visible now. We can see it in the not the
You
presenter
can,
mode, but yeah, now it's presenter mode. Perfect.
okay, great. All right. So this is Nora, who is a little over 4-year-old spayed female Tibetan Terrier. That should have been the quiz question if you recognize what breed she is. She presented with a 2-week history of a progressive hyporexia and lethargy. The owner felt it began one day after receiving a dose of Credelio. Her last full meal was 2 weeks prior to her presentation, and otherwise the owner for about the last week had kind of been force feeding her some baby food. She had one day of multiple vomiting episodes over a 6-hour period and that was about 3 days prior to presentation. The owner reports no additional vomiting since then or diarrhea. She was seen by her local veterinarian about 1 week prior to presentation. At that time, they found a mild azotemia. They had her back and forth for several times over the period of the week for just some subcu fluids. They had sent her home with some meropitant, but the owner had not administered any of that medication, but they also felt that her energy level seemed a little bit better with, I guess, the sub-Q fluids. The most recent blood work prior to her presenting at Tufts consisted of a complete blood count that had a hematocrit of just a little over 50%, whites count in the upper end of their normal range at about 11,800. Her chemistry showed a normal blood glucose. Her BUN was 46, creatinine was 2.2, her phosphorus was 7.7, potassium 4.2, with an albumin of 1.7. The remainder of the chemistry was within the normal limits. Her urine was pale yellow with a 1031 specific gravity and a pH of 6. Urine protein was 500. There was a notation made of suspect cocci and rods and maybe non-hyaline casein. Urine culture on that sample was negative, and they had performed a baseline cortisol, which was normal at 2.96.
I have a question. Was the urine free catch? And that might be where we saw the rods and the cocci, or
It was unclear
okay.
from the notes in the record,
But it would culture negative, so we
but
don't
it
know what
cultured
those were really.
negative.
Yeah.
Yeah.
Okay. And you said the cortisol that I mean, those values don't jump off the top of my head. So that was within normal range for the cortisol levels.
Yeah, for
Okay.
arresting cortisol to rule out a Addisonian or
Yeah.
is anything above 2.
Okay. Cool.
Okay, and her weight on presentation. So at that point, they referred her up, and she came and presented through our emergency service. Her weight at that time was 9.8 kilograms. Temperature was okay. Heart rate and respiratory rate were recorded as being normal. She had a normal body condition score of 5 out of 9 with a normal muscle condition score. They assessed her as being just maybe 5% dehydrated. The remainder of her physical was otherwise unremarkable. A PCV total solid BG and a lactate in our world, that's called our big 4, was 46, 103, and 1. An ISTAT had a creatinine of 7.7, a BUN of 91, a sodium of 140, and her blood pressure was noted as being hypertensive at 187/95 with a MAP of 117.
And then before we move on, can you go back to that slide? Sorry. I
Oh,
just want to make
sure.
sure that all of the pathologists on the call. So what time frame difference is it between her creat that was 2 at her referring vet and it got to 7 when you guys, like how long of a period was that?
It was like a couple days.
Okay.
They suggested she come up. They thought about it from what I could gather from the record, and then she continued to not feel well, and then they brought her up.
Okay. So, not even looking at the actual values. Like obviously the creat of 7.7 means that she's severely azotemic. So, but for the pathologists on the call, especially the non-clinical pathologists, um, even let's just scrub those values. But when you double your creatinine in a period of 24 to 48 hours, then that's even if it's still within the reference range, or maybe it's just mildly borderline azotemic, that's still evidence that there's an acute kidney injury. Obviously, you need to make sure you're hydrated and everything like that. But she more than doubled within, 48 hours. So that's something is more recently happening. This isn't just CKD that's stable, obviously, right? So there's something that even with whether it started prior to the referring vet and it just progressed over time, and so now we're catching it at a worse time point, very possible. But that's very concerning that we have two values that are pretty close together and they are substantially different. And then also the hypertension. Does anybody in the pathology world, not the clinical world, because you guys should know all this, do you guys know what the cutoff is for hypertension in a dog? What's the systolic blood pressure that we worry about for diagnosing true hypertension as opposed to pre-hypertensive? I'm going to call on you, Dr. Amerman, because you're the only pathologist that, oh no, I see Dr. McLeland, but I'm going to call on you still, Dr. Amerman.
I think this could be wrong, but I have like 140 or 150 somewhere in my head. Is that too high?
Okay, so 140 to 160 is considered pre-hypertensive, and then once you
Gotcha.
hit over 160, you're truly that's the iris cutoff for hypertension. Please,
Okay.
clinicians, speak up if I'm wrong, because I could also misspeak that as well. And
No,
then
you've
then
got
the
it right.
Okay, good. Okay, so 160 over 160 is hypertensive. The 140 to 160 range is considered pre-hypertensive. I guess one way back when Irish used borderline hypertensive, but now they say pre-hypertensive. I'm not sure why, but that's what the category is. And then the other thing that they also measure or state about it when you're looking at hypertension is um, hypertension with end organ effects, right? So not only do we know the blood pressure measurement, but we know we actually have, vascular damage in retina or something like that. So there's more, there's another subcategory, I guess, of hypertension is like when you know you have end organ impact because of the blood pressure changes. Does anybody have any questions? Oh, yeah. So thank you for putting in the chat. We'll put, Haley, could you type in the correct answer? And then we can move on so that everybody sees in the chat. Thank you guys. I'm glad we participated. Okay, move
Okay, so right now that we've generated a problem list between the local veterinarian and our ER is that we have what would appear to be an AKI with a worsening azotemia. The referring vet had done a leptoELISA and it was positive, although she did have a history of recent vaccination. We've got proteinuria, severe hypoalbuminemia, and then our ER did a TFAS and identified some pleural effusion right over left, and she's hypertensive. So initial treatments were, they got her started on some Cerenia, amlodipine, unison with this question of is this truly an acute lepto case in our neck of the woods? At the time of year she presented, it's the start of our lepto fall season. And then a moderately conservative dose of LRS just to correct any dehydration that was there. And then they had gotten some full body radiographs and found a bicavitary effusion. Otherwise, the abdomen, they didn't see anything else in her abdomen. They did know L3 to 4 mild suspect disc herniation. And so she was transferred to the medicine service. We continued treatment, started some additional treatment, and the plan was to perform an ultrasound-guided kidney biopsy to see what was going on. She did have sufficient numbers. I forgot to note the number, but she had sufficient numbers of platelets. She was not thrombocytopenic. We did perform a thoracocentesis, removed about 100 mils of straw-colored fluid, and cytology on that was a pure transudate. I included here some of the ultrasounds, her right and left kidney, for you to take a look at, and the radiology report described a kind of lacy hypoechoic area, almost anechoic region within the spleen that they felt was most compatible with either infarction or inflammation. On her kidneys, we see hypoechoic regions devoid of blood flow within the left kidney, particularly. The structures and they thought, okay, some of what else they were seeing here could represent, and I don't know if my cursor will be seen, kind of represent areas of infarction or necrosis. They couldn't rule out at that point a renal abscess or tumor, but everybody's consensus was that they seemed less likely. There were evidence on both kidneys of renal infarct. There was a small amount of anechoic effusion. There was some echogenic material in her bladder, and they thought that might represent actually kind of a conglomeration of either debris, given some with her lack of blood flow to the kidney, that we might just have had some debris coming south. All right. And so we sent her off, we biopsied her and sent the samples off to the service here, and her morphologic diagnosis. Should I not show this, Rachel?
No, it's fine. It's gonna be pretty obvious, but I think it's very helpful for us to know that there was systemic vascular problems because I don't think that was very much communicated at the time of the biopsy. As you see, this word that we have in the morphologic diagnosis, the term crescentic, is not something that gets used in a diagnosis very often by us. So for all of you that have biopsied and performed biopsies, has anybody raise your hand if you've actually gotten a diagnosis of crescentic from us? I can see Texas A&M is here. We've got Friendship here. We've got a little bit of OSU. Anybody gotten a diagnosis of crescentic?
Other than Tufts?
Other than Tufts. I think I probably diagnosed it at Friendship like once or twice, but that's because they send everything to us.
I think we've sent you one or two others that have, but it's been like really sparse over the
yeah,
years.
it is very uncommon. So I'll show you some of the lesions that lead to that diagnosis. So I'm gonna start sharing, make sure I've got my right screen up though. That's the correct thing. That's not
I think
that.
I just stopped
Yep,
sharing.
you did. I just want to make sure I'm going to be showing the right thing once I get it up there. So, the crescentic is a type of glomerulonephritis that is uh, often used in human medicine. So human patients can develop crescents in their glomeruli quite well. Let me say this. When we're looking at them in biopsy rounds, so they're the ones that are of interest, so we show them in human kidney biopsy rounds. So we probably have a crescentic case once every week. So thinking about the frequency, they probably only choose the cases that are interesting, and they're probably the ones that have crescents and stuff like that. And those are the really severely sick patients anyway. So it's not uncommon to come across a diagnosis of crescentic GN in humans. And then when we're thinking about what causes crescents in humans, there are three main things that we use as differentials when we're quizzing the MD nephropathology, or sorry, nephrologist, the MD nephrologist that are rotating through the service or coming to rounds. And so two of the diseases that are common causes of crescents include anti-GBM disease or good pasture syndrome, however you want to term that. And so that's when you have a direct antibody attack against the type 4 collagen or the good pastures antigen in your GBM. And so that happens in humans. I have never seen a case in dog or cat. So therefore, that's one of our crescentic causes that doesn't fit or doesn't fit with dogs and cats. The second cause that will cause crescentic GN in humans is anti-neutrophilic cytoplasmic antibody. So ANCA, if you guys have heard, I mean, most of you guys have heard, because most of you guys are actually board certified pathologists, or not pathologists, excuse me, board certified internists and stuff like that. So ANCAs are when you make an antibody against a component of the neutrophils. And there could be various neutrophil components that can incite antibody production. So think about it. If you have an antibody attacking a neutrophil, the neutrophil is going to explode. All of those digestive enzymes that the neutrophil is carrying is going to release out into the serum or the plasma, and then it will damage the glomerulus. So ANCA disease happens a lot in humans. I've never seen a case in dog or cat that has attacked the glomeruli. ANCAs do exist, at least in dogs and probably in cats. I think it's been reported in cats. So the antibodies themselves exist, but I've never seen them damage a neutrophil population such that the glomerulus is damaged. Does that make sense to everybody? I need a yes from somebody.
Yes.
Okay.
Yes.
Yes.
So that's why, so two of our main causes of crescentic GN just don't exist in dogs or cats or have yet to be seen. And we've looked at a lot of samples at this point. The third cause of crescentic GN is usually immune complex disease, which we do see in dogs and cats, right? Oftentimes we see crescents in the setting of lupus or really, really bad glomerulonephritis with immune complexes. So that one does happen in dogs or cats. So that would be our limited scope of why we see fewer crescents than human medicine. Now, that being said, there is a species that likes to form crescents in their glomeruli when they have any kind of damage, and that's pigs. So I see crescentic GN in pigs whenever somebody's showing me a fun case. It's usually a crescentic GN pig. So I don't know. There's something about the pig glomerulus that's a little bit different that would probably allow it to have crescent development. Now, so I keep using this word crescent. And I'm talking so you guys are seeing my face and not my actual pictures. So hopefully now you guys are seeing a core of a glomerulus. Is this correct? Two biopsy cores?
Yep.
Okay. So I'm showing the trichrome first, and maybe I don't want to show the trichrome first. Can I go back? Oh, hold on. That's what I knew it was going to do this. Okay, well, I'm just going to show it because we're already here, and it actually has the prettiest pictures. So we have two excellent cores. And we have this area here, which has a lot of collagen. This is the renal capsule. So all of this is cortex. Hopefully you're kind of seeing these little globoid circular structures that are identifiable as glomeruli. As we traverse through the renal cortex. So remember, when you're taking a biopsy from a kidney, if you are talented at this, like Tufts is, you are going to direct your needle so that it's kind of going to go along the long axis of the kidney. You're not going from cortex to medulla. You're not going inside to the kidney. You're kind of cutting along the long axis. So we're getting lots of different little lobules per se, or lobes, maybe even if it's long enough core. So we're getting a lot of those different aspects along the linear aspect of the kidney. And so we're only getting cortex in that particular core. And then we go to here. We have a little bit, well, this is still cortex here. And I think most of this is still cortex. So we've got good samples. And I think we had a good number of glomeruli. So we've been talking about the word crescents. So we're going to skip this glomerulus that's kind of jumping out to us as looking like glomerulus. That looks like it's fairly normal. We'll go back and look at it because it's fun. But we're going to go to this guy here. And there is, oh, it's a little bit out of focus, so that's kind of frustrating. But hopefully you can see that it's a circle. So we have a glomerulus. All of this blue material is the kind of compressed, condensed collagen. And then anything kind of sitting outside of the glomerulus, so outside of the glomerular base membrane, you should, in normal glomeruli, only have two cell layers. You should have the podocyte and you should have the parietal epithelial cell. So let's go maybe to this guy who's a little bit more normal, and we can see that we are fitting the criteria. So one, if you, depending on where your nuclei are, right? So you can see us, whoa, I don't know what that, just had a seizure. So here's our podocyte nucleus. So we have one cell layer. Over here, we have a few like parietal epithelial cells that you can actually see their nuclei for. But again, you only have the podocyte layer and the parietal epithelial cell layer. And this is this is not a normal glomerulus, but it at least has the right number of cells in Bowman space. And if we go to, oh, this is a better one. Okay. I think this is what I meant to show originally. So hopefully you guys can see this blue material in here. All of these kind of pale, yellowy, like orangey green things, those are red blood cells. And so this I'm outlining. Oh, maybe I can actually draw. Let's see if I can draw. I do not necessarily. So that's probably the full oh, shoot. That's probably the full aspect of the glomerulus is right here. Okay, so that is the glomerulus, and everything outside is extra cells. And so, and there's not only extra cells, it's extra matrix, and sometimes it's inflammatory cells. So the cause of a crescent is when the glomerular capillary wall ruptures or Bowman's capsule basement membrane ruptures. So it could either be a glomerular capillary that explodes and everything that was in circulation goes out into the urinary space, or Bowman's capsule ruptures and anything that was inflammatory in the interstitium goes into Bowman's space. Does everybody get that? So all of this extra material here is part of the crescent. And so you can see that not every glomerulus has it, right? Like we went through that one glomerulus that looked like it was like it did not have a crescent. Here's another, oh, here's a great one. This one is so beautiful if you think that pathology is beautiful. So see all of these cells here, these are all probably podocytes or maybe parietal epithelial cells. So the cells that can be in a crescent include the natural cells that are there, so podocytes and parietal epithelial cells. They're not supposed to be able to proliferate, but in weird situations they can do it. You'll also see inflammatory cells and you'll see extracellular matrix. So like a little bit of fibrin in there as well. And then what that does is it's a space occupying lesion. So therefore the rest of the glomerulus kind of gets squished together. Do any of the pathologists know what, and this is a pathology trained question, do you know when we're talking about crescents, there's one other lesion that can be confused with crescents? Does anybody know what that is? Shannon, I'm calling on you. If you can speak, you might not be
Sorry,
able
I'm
to.
slow. Um, are you talking about like when there's just parietal cell hypertrophy?
Yes. And well, it's not only hypertrophy, but it's also proliferation. So it's a
Yeah,
type of, it doesn't have immune complexes in it. Do you know what that lesion's called?
I'm drawing it like tubularization of the.
Okay, so we can talk about that. That's a little bit different. What the thing I was looking for was collapsing lesions, which is weird
Oh,
because we really, I mean, we say we don't diagnose crescents. We very rarely diagnose collapsing FSGS. So that is basically just proliferation of parietal epithelial cells and podocytes. But it's actually like it is actually cell proliferation, not just change in shape. And so when they proliferate, because the podocytes, and remember FSGS is a podocyte problem, that it gets bottled up into the categories of FSGS, focal segmental glomerulosclerosis, and the proliferation again causes a mass lesion, and then the glomerulus kind of like shrinks down into being a small, little like nubbin of collagen. We see that in humans associated with HIV infection, and we can see it in certain other diseases in humans as well. I think I've diagnosed it maybe twice or three times in cats. It's only been something I've actually been confident of in cats. But I don't know if I've ever seen a true collapsing features in dogs. But when we're at MD rounds and we're looking at crescentic, we always kind of say, well, it's not collapsing because there's matrix there. There's fibrin there. There's some inflammatory cells there. It's not just proliferation of the parietal epithelial cells and the podocytes. It is actually like there's something has broken apart to allow other cellularity and other matrix components in there. Thank you for volunteering to be on the spot. As I told you, you're going to speak up. Not necessarily volunteering, mostly being voluntold. I appreciate it. Okay, so now we're looking at another glomerulus. He does not have a crescent in him, or she, they, whatever. But we have capillary walls, and we are noticing there's a lot of red material along the capillary walls. Um, and this was repeatable in many glomeruli. This was, they're not truly, I don't know if they're truly red nodules or if it's just a whole bunch of red material. Maybe it is truly red nodules and this is just slightly blurry. But there are concerns here for immune deposits along the capillary walls. Okay, so that's something we can see on trichrome. In general, in the non-crescentic glomeruli, I don't see a lot of hypercellularity. I'm not seeing a lot of cells within capillary lumens. I'm seeing probably the right number, maybe slightly increased mesangial cells. But in general, it's not a severely hypercellular glomerulus within the capillary tuft. Now, these nuclei out here in Bowman space can give the false presentation that it's a truly hypercellular glomerulus. So a lot of people who don't have experience with glomeruli would see this nucleus and count it as being a mesangial nucleus or an endothelial cell nucleus, and they're wrong. It's a podocyte nucleus. And so they might look at it and say, okay, I think this is a hypercellular glomerulus, but in general, it's just really prominent podocytes. Does anybody have any more questions about we're going to look at the vessels in just a moment, but does anybody have any more questions about the glomeruli? Is anything on the chat? I'm not looking at the chat. Dr. Hokamp, you're in charge of the
There
chat.
was, yeah, sorry, I logged in late. I'm on
No, it's fine.
ClinPath. There was a question. Sorry, hang on. I have to put my glasses back on to read it.
We had a comment. I made them put comments about hypertension. Is that what that's in there?
Well, it says a question about also with Alabama rotten dogs. I think you were talking, I think it
yes.
was back when you were talking about when we see crescentic lesions, I
Yes.
think.
Okay, yeah, we can see the same kind of like blowing apart of glomeruli when we see that Shiga toxin associated glomerulonephritis in dogs. So thank you for whoever added that. So it's easy to remember Alabama rot. It's such a fun term to say. But what we mean by that is when they have exposure to E. coli that probably is producing or releasing Shiga toxin. That can cause glomeruli to rupture and have a whole bunch of fibrin come into Bowman space. There is a separate type of very similar pattern in dogs, and that's what we've seen in the UK. We still have not definitively identified the cause for it. There are some suspects that have found a link, and I honestly can't even remember what the infectious disease is anymore. I'm going to mute myself because I'm going to blow my nose for a moment because it's getting a little gross in here. Hold on one second. No, I'm not going to mute myself because I can't figure out how to do that. Oh, here we go. Got it. I'm so dainty. Okay. So in the UK, they have an associated, or they have a similar pattern where there is like fibrin and rupture of the glomeruli and fibrin in Bowman space, hemorrhage into Bowman space, inflammatory cells into Bowman space. And so when that originally happened, I think in like 2012, and it occasionally just seems to be seasonal associated as well. They often have a vasculitis in their skin. It is published. We did the electron microscopy for those cases, and we didn't see any immune deposits. It's not immune complex driven. It seems to be mostly direct damage to the capillaries and the endothelial cells. And so that can be another associated crescentic type lesion that we get to see in dogs. So thank you for referring that. Okay, so we have kind of a variety of glomeruli. We have some glomeruli that look like they are not hypercellular, but they do probably have red nodules or red dots along the capillary wall. And then we have the other glomeruli that have crescents. We have some that are completely blown apart, and it's even hard to identify that they used to be glomeruli. Sorry, my dog is trying to get into the camera photo. So when we report this, it's important to say how many glomeruli have the crescents, and then how many are non-crescentic, just to give the clinician an idea. Is this just like a once in a blue moon thing, or are many glomeruli affected with similar lesions?
I have a quick question.
Yep.
I don't know, maybe you mentioned this. There looks like there's like either tubules or arteries that are just filled with like a
We're going there. Yeah,
homogeneous
that's our next thing.
proteinaceous.
Yeah.
Oh, okay.
So that's the other part that's really interesting for this case. So not only do we have blown apart glomeruli, and it's good that the trichrome shows this. And I'm glad you picked up on that stuff. You can be an honorary pathologist for the day. I'll let you read all my reports. Okay, so I guess first of all, and if I can get the H&E up, I hope that you can see there's a little bit of difference in the staining quality of this part of the core versus the staining quality of that part of the core. And it's a little bit more obvious when we get to the H&E. But this part looks a little bit just like kind of more washed out, and the blues aren't as blue. And then if we go, this is exactly what Dr. Skinner was alluding to, is that we have these vessels, and there's much more prominent ones. So I'll show you those too. But I'm here, so I'm showing this one. We have this artery that's kind of tracking along here. It's going up towards, the cortex in here. It also extends into this glomerulus. This glomerulus is completely blown apart and has a crescent. We have all of these inflammatory cells kind of hanging out in the lumen. We have a little bit of plasma kind of insedated into the wall. So we have some degree of vascular damage, and it can get from that, that's, probably an intralobular. I always have to say those slow. And then we have some that are maybe just a little bit thick-walled, but hopefully you can see how kind of uh the amount of kind of fibrosis that's around it in the interstitium. Where are the pretty ones? Here it is. This is the one we were looking at. Okay, so this is probably what drew Dr. Skitter's eye. So we have an artery here. We have lots of cellularity around it, and we have this kind of we have this kind of red material kind of being pushed out into the arterial wall. So some of the blue stuff is probably just plasma, but all this red material is probably fibrin. So when the trichrome stains the fibrin, it stains fibrin, it's usually red to orange. And then we have this cellularity all around it. So we do truly have an arteritis, and we have fibrinoid degeneration of the wall. And so it kind of tracks up along here. And just to be clear, what if we didn't get this artery in here? It would be very hard for us to say what is the cause of tinctorial change and what is the weird part that the ultrasound said was weird blood flow. It would be hard to differentiate that. But so we were lucky to get this totally blown apart artery that has fibrinoid degeneration of the wall and inflammation around it. Let's see. I know this is going to be the problem. I'm going to stop sharing for a moment. I'm going to get up to the other stains. Let's see, one more question. And please, if you guys have other questions, let me know what they were. It's thinking. Okay, that's still the other one. Okay, I need to go back. And I guess I'm going to ask, and we'll have more information about this, is that is whether or not other organs were biopsied. It doesn't sound like it, Dr. Lobato. Like it's not like we could look at the spleen to see if the region that they were worried for an infarct was truly an infarct, correct?
Correct. It was strictly a kidney biopsy.
Okay. So now I can show you this one. This one's going to be the H&E, and it's going to show you the infarcted area. So remember I said in that the trichrome, I was like, this area looks a little bit paler, and now I'm actually going to prove it to you with the H&E. So here we're looking at the H&E, and you guys can see all of these tubules in here. If there's anyone in this room that can tell me that these tubules are alive and that they're viable, please raise your hand. I'm saying that so nobody raises their hand. So all of these tubules have coagulative necrosis, right? Like the shell shape is there, but their nuclei are completely disparate. They have vacuolation, they have kind of like rarefaction of the cytoplasm. And so this isn't just the type of necrosis that we see commonly in ICGN, where it's like one cell dying, another cell over here dying, and they're like kind of detaching. This is entire tubules dead. Entire regions of the tubules are dead, right? We have a little bit of response, so there probably has been some degree of reperfusion because we've got a few neutrophils coming in here. It was probably infarct, and now we've got a little bit of reperfusion response based on the presence of all these neutrophils coming in. Here are probably actually dying cells with their nuclear debris kind of actually like this one's a little bit more recent. And then if we go to where this infarct was, it was immediately adjacent to that first vessel that I showed you. So here's that vessel I showed you, and I said it kind of blew apart this glomerulus, and I said there were a whole bunch of neutrophils in there in that vessel, and that's exactly what this is. So we definitely have vasculitis. We definitely have crescents. We definitely have the kind of glomerular changes that were suggestive of immune complexes. If you go back down to the other one that was our other really bad vessel here. So look at this vasculitis. Like this used to be an artery. It is completely blown apart. I'm gonna ask this for a ClinPath person. Mary Nabity, are you on the call? I think you are.
I am.
What are these structures here? These red things.
This is H&E, right?
Yes.
It looks like I think there's red cells, although
You're
yeah,
right.
I think they're red
Yeah.
cells.
So where are the red cells kind of why are they in this kind of big, ovoid shape. Like what's this? This one's a good one. You can see what this. Where is this? Where is
Well,
this
that
red
looks like a
cell at?
little tubule. Yeah,
Yeah,
so
so
these
we've got
are
red cell
tubules that are
cast.
all trashed.
Yeah, well, yeah. So it's like
Oh
it's a
yeah,
true. This is a true red cell cast.
cool.
So we have a tubule here. We've had hemorrhage through the glomerulus. It's come out in a Bowman space. It's gone down into the tubule, and now it kind of those red cells as they get broken up and stuff like that, they kind of also get entrapped and mixed with a little bit of the Tam Horsfall protein. And so you'll have true red cell casts, which are going on here.
But those tubules where you were first pointing out, they just look trashed. Are they like
Right. I think, yeah, I think those early ones either this might be a little bit of epithelium. That's why I think this one's a little bit easier to see it was a tubule. But yeah, this would be consistent with a tubule and not a vessel. And I would say it's just because I'm like that's maybe I'm using my level of experience of having looked at these for so long. But this one, everybody can agree this red material is hanging out within a tubule lumen. And it's
But
got tubular epithelial cells.
were any red cell
Um,
casts seen in the urine?
I do not think so. I think there was a little bit of hematuria. Did you have free red blood cells in your UA?
Uh, let me hold on a second.
And we
I'm
also
trying to,
got you guys also submitted urine, so we should have an like a our
we should have we sent in, I think, for an SDS.
Yeah, we
yes, you did. I
rarely.
think it's probably just in one of the long lists of
Yeah.
There were, if there were, it wasn't marked because I didn't write it down.
so we had on the urine you sent in, we had 3+ blood, but I don't, and then it said suspect cocci, rods were definitely present. Red blood cells 3 per high power field. I'm trying to look at your cast. This is no Highland casts, no non-Highland casts. Okay, so none of the casts were flagging whenever with the I get you guys are doing this in that automated urinalysis, right?
Yeah, but this is also
Yeah.
being verified microscopically by somebody as well.
Okay. So yeah,
Um,
casts were not detected, but there was 3+ blood in the urine. But we also have this disconnect between seeing casts in the tubules in dogs and cats and seeing them in the urine. Whereas in humans, you usually do pick them up in the urine if they're having red blood cell casts in the tubules. So some reason dogs and cats do not like to keep their casts intact by the time they're evaluated on a urine sediment. Okay. I know we're getting close to time, so everybody wants to see the EM, I'm assuming, to see if there are deposits. And I'm going to say it's an annoying case because there are, but they aren't very common and they're not really in the right look. Well, I shouldn't say that. I'm going to say this. When we have the trichrome that has kind of that red appearance along capillary walls, sometimes they're really discrete dot, dot, dot with the trichrome. And we can be very confident that even on light microscopy, there are deposits. And sometimes if I know, like, it's a money case or something like that, I'll be like, hey guys, like this is enough to call it. You should probably just go and start treating, and we don't have to do the EM. Like, let's not spend the money. Like, let's spend the money on treatment and not necessarily on electron microscopy. So this case kind of almost had like it had red material, but it wasn't super like discrete dots on the trichrome. There really wasn't the same kind of like there wasn't the typical remodeling we saw on the Jones. And unfortunately, there were no glomeruli in the sample that was submitted in Michelle's. So we don't have immunofluorescence for this case because that particular sample did not have glomeruli in it. So that can't be one more supporting piece of evidence to show the presence of deposits. But we do have electron microscopy. Which one? So one of the gloms for EM had a crescent in it. And not remember, I will say that when we look at these, I also usually ask the person who trims these because they're usually trimming them and then they also scope them depending on the case. Sometimes they send it to me to scope, sometimes they scope it themselves. But if I'm confused about like, hey, I'm not sure where I am in the glomerulus, they will take a picture of the toluidine blue section. And the toluidine blue section is taken prior to putting it into this EM grid. And it's to show, like, as you're cutting through a block, you're like, do I even have glomeruli? Should I actually waste a grid? And once you see a glomerulus in the toluidine blue section, then you're like, yes, I have a glomerulus. I'm going to put the next section into a copper grid. We'll scope it. So you have, we do have pictures of these on the toluidine blue to show that one of them had a crescent in it. And then the others, the glomeruli are very wrinkled. You can see the capillary wall. I'll probably outline it right here if you can see this. Let's see if I can draw. So you guys can see. Let's see if we can do this. We'll see how good I am at this. So this is a capillary wall, and you can see how wrinkled it is. Again, wrinkling of the glomerulus usually happens with ischemia. These are probably near or adjacent to the area that was infarcted, or to an area that was infarcted. And then you can see in this capillary lumen, we have a very swollen cell. We have a prominent nucleus, but really, it's really even hard to find the capillary lumen in that particular glomerulus. And we found a few deposits. So like if we're, and I need to zoom in, 1 second. Image, enhance. Okay, so when we're like looking at this, like these little densities along here are most likely the immune deposits. And because we don't have IF, I can't verify it. But this is probably that red material that was showing up on the trichrome. And there are a few others. It might be easier if I show you the final report. 1 second. So the issue that is difficult with this case, however, is that I was expecting to see a lot of deposits based on what I had seen on the trichrome. However, now I want to show this one. When I see the actual glomerulus, these are electron densities. They are within the GBM. And so that's probably what that is. But it's not a striking immune complex. So I was looking for this picture. Okay, so let's look at this guy a little bit more. Zoom in. Now I have to do it this way. Hold on. Okay, so we're seeing here, we've got this capillary and we have these electron densities here. And we have 1, 2, 3. We have all these over here. We've got all these kind of coming along that particular capillary loop. And here we are subendothelial. So the deposits are mostly, when we see them kind of within the GBM, they are not striking. They are not very prominent. Very acute glomerulonephritis will have smaller kind of scattered deposits, and that's just usually like a anecdotal scenario that we talk about in human medicine. Like if you have a really bad GN and you're looking for deposits, like they might just be very small and very uncommon because it's so acute they haven't had time to enlarge. So we're not super concerned when they're small. This might be another area. Oops, sorry. Now I gotta go this way. Where we're seeing them like right here in the capillary wall, right here in the capillary wall, here, some here. So they're more like subendothelial to intermembranous as opposed to subepithelial, which is kind of the picture I thought it would be subepithelial based on the trichrome, but instead the kind of electron densities are really kind of vague and they're within the GBM and within the mesangial zones. So I was very confident to say crescentic, very confident to say the vasculitis portion, and said that this is most likely driven by immune complex disease for the glomerulus. What's happening with Nora? Is she okay?
Yeah, well, let me show you. Give me
I'm gonna stop sharing. I'm hoping everything's
yeah, well, she's still with us. The owners say she's not doing all that well because, am I sharing? Can you see this?
I don't see anything right now.
Okay, hold on then. Let me try to. She's not eating well on her own. They're basically doing all E-tube feedings. She originally went home with, she was treated with enoxaparin. While she was in the hospital, we hit her with some DEX-SP. I'm assuming you're seeing this.
Yeah, we can see it. It's
Okay.
it's not the presentation mode, but yes, we can see it.
Oh,
I'm
okay.
gonna admit I don't know what enoxaparin is. A very heavy antibiotic. What is enoxaparin? It's
No,
not
no,
my.
we're trying to break down her clot.
Oh yeah,
It's
yeah,
an
yeah. That's an antithromb. Yes. Okay. Yes.
it's
Okay.
an
I do.
antithrombotic.
Yeah.
And so while she was in the hospital, Dex-SP, enoxaparin, some ondansetron, we were concerned about her overall appearance. So they actually started her on some benazepril with spironolactone. She's still on the spironolactone, but when we saw her UPC on recheck, she was transitioned to telmisartan. She was on a really high dose of pred orally going home with a taper, and they're just about finished with the taper, or now, or she may actually have finished with some clopidogrel. What's interesting is look at her values. Her initial UPC was 17.8. Her creatinine here was that initial 2.2, the jump into the 7 range, hit her with some steroids and fluids, 3.4. Her last creatinine was 1.4. That was like a week ago.
Oh wow. Okay.
And her phosphorus peaked at around 12 and a half, and is down to 6.4. Her albumin staying about the same, which doesn't surprise me considering that we really haven't bumped her UPC
Yeah.
at all. But I don't know what to do with her at this point. I mean, right now she's on mycophenolate, telmisartan, some amlodipine still for her hypertension, and let's see what else. Clopidogrel and renal support, diet through her E-tube.
Did
Have
she,
you?
I'm sorry if I missed this, did she have extensive infectious disease testing?
She did, at least as extensive as we will do up here. I mean, she didn't have any travel history outside of New England. So we did our typical tick serology. We did pursue lepto, and did a full map panel, and all of those were negative.
Have you thought about, and I'm not a clinician, but I know that friendship is often more recommending like cyclophosphamide if they're not getting much response with mycophenolate. And this, and I would say for areas that have really bad glomerulonephritis, sorry, for biopsies that have really bad glomerulonephritis, I think that cyclophosphamide would maybe be more quick acting than
Yeah,
mycophenolate.
yeah, that's probably what we'll do. Uh, this UPC was from the 12th. So we
Okay.
haven't, yeah. I have to actually
Any
check with I have to check with my resident, who unfortunately is in oncology right now and has had an appointment, as to whether I don't think she's made that change with them yet. But that's typically what we'll go with. Lately, we've been skipping cyclosporin and going right to cyclophosphamide.
any other clinicians in the call have other recommendations? I mean, it would be nice to get an anti-CD20 available for dogs. I keep saying that. I mean, we know it's I think it's coming.
And she's never had any cytopenias or anything else that would be like possible SLE or something like that.
Not that I've noted a lot. They live a few hours away, so I was trying to go through the referring vet lab work, and I did not see any from the initial, like, late September, beginning of October, where they had some other blood work for some other reasons.
Sorry, I think I missed this. You said you are putting her on cyclophosphamide?
I said I think that will be our next step. Yes,
What doses have
to
you been
rec.
using?
I'm sorry.
What like doses and frequencies have you been using?
The lowest dose, like 3 days on, 4 days off. I think I want to, off the top of my head, God, you can push. I always have to check because I don't switch them all that often. I think a mg per kg.
Stephanie, is that similar to what you guys have been recommending?
Well, yeah, what are you using, Stephanie?
Um, I had a dog on like 150 mgs per meter squared every 3 weeks, and all of her white cells and red cells went down, but her proteinuria didn't improve. And then I
Did
put her
not
on,
improve?
they did not, her UPC didn't improve at all. She was neutropenic and leukopenic though.
And that was on the daily or on the
That was on
Q,
like
like
every
3 days?
3 weeks.
Just one dose every 3 weeks?
Yeah.
Okay.
And with furosemide, which is, I think after talking, I just asked what our oncologist did and did what they do. And then for that dog, I switched her to maybe like a daily dose. I was like, maybe more frequently we'll do something. How I put her on the metronomic dose. It was like ended up being like 12 mgs per meter squared daily. She was a Frenchie, so I had to get it compounded. So I got it compounded with furosemide, which is also what our oncology service does. And then she was on that for 3 months and still had zero improvement in her UPC. So
We've actually discussed this case, haven't we?
yeah. Oh, this is Millie Alton.
Yeah.
Yeah. So Stephanie, what you're telling me is I should do what you haven't done.
Yeah. So maybe what you're doing, which is the one thing I have not done yet, is the answer.
I mean, I think it goes to the point that we kind of like we've been mycophenolate is our grab like off like we grab that first and then some don't respond or some have so many side effects that we don't want to use that and so then we have to do but we need to get this out like we need to be I mean if it's not successful we need to put it out that this is not this sometimes works or it does work in these certain scenarios but
And like
it would be good to have
Millie
that.
tolerated it. Like her white cells were never low enough that it was a concern. She just had zero improvement in her proteinuria. And like she had the multiple SDS pages, which all looked exactly the same.
Yeah.
So
the other thing I think we've seen a few times at CSU is Rachel knows this, but a fair amount of our immune complexes have this vasculitis as well.
Yeah.
And I feel like that's more common for us than it is not to have vasculitis in a lot of our biopsies. And I will say, I do think those that have that do seem to either take longer to respond, like way longer than normal, or mycophenolate is just simply not their drug. I have also not had good luck with cyclophosphamide, either doing the every 3 week or a couple days on, couple days off. I don't know if we're choosing the wrong cases, but we've only done it in 3. So it's not like I have 20 dogs, but it's interesting because I do think the ones that have concurrent vasculitis may take longer than usual. And with how much damage has, occurred, I wonder if it's just going to take a little bit longer, plus minus.
Yeah.
Maybe you'll have some residual proteinuria just because of the amount of damage, maybe too.
Sarah, have you associated it with any of your infectious diseases that you see out there?
No.
More so than others? No?
Nothing. Yeah. And it's kind of strange because we also have a very weird, hopefully we're going to publish it, but they're seeing it at UC Davis as well. We're also seeing a weird granulomatous hepatitis with a vasculitis, and both of those seem to be immune. And Rachel at least has seen one of them. We had one dog that we did liver and renal biopsies on that was bright yellow and had all these similar lesions, but none of them so far have had infectious diseases and have actually survived and basically have all responded to prednisolone, not any other immunosuppressants.
Have you tried adding with these primarily like vasculitis cases, pentoxifylline, or has anybody done that as ancillary therapy?
We certainly, when we talk to dermatology, they usually go, I mean, you can. And then, so then I don't feel like it's that resounding of a, thing to recommend, but we have certainly tried it. I suppose for us, a lot of it just seems that the dosages that, they say that helps with the vasculitis, they often get gastrointestinal side effects. So then, they're azetemic already. They may already have an E-tube in. It seems to make them feel worse. So in many of the cases, we've just dropped it because we didn't think it was worth it. At least that's kind of been our experience.
Yeah,
Yeah,
well,
and one of our past criticalists loved that drug. And same thing, I feel like by the time that we usually think of it, it's either too late or we're not using it's just not working for us.
Yeah, I
Yeah.
can imagine that those areas that are blown apart, like that whole area of the kidney is going to be an infarct, a chronic fibrotic area. So, and then if it's happening in other organs, like you have evidence that it's also in possible infarction in the spleen, maybe there's some in the GI tract that's also making some of the nausea and the whatever. So this is like almost this is more of a systemic scenario
Mm-hmm.
that you're going to have to cure or not cure, but deal with all the vasculitis elsewhere. So, I think this, I'm very happy. I know we're over time, so I do want to end and say that we're going to have rounds again in December. And thank you so much, everyone, for participating. It really does make me happy to hear other people's voices. And we think we probably have a case. I'll just double check time with Jess Herman. We have an interesting cat case. And so we can discuss that one in December. And please let us know if there's any other cases that you would think for further in the year. So thank you guys.
Thanks, Rachel.
Thanks.